and welcome all of you, all the faculties and delegates to today's webinar. It is a cutting edge webinar which is organized by Pune Obs and Gynec Society in association with Ahmedabad Obs and Gynec Society and Baroda Obs and Gynec Society. So I welcome you all. Myself, Dr. Kanchan Durukar. I am a fertility consultant from Pune. I welcome all the faculties and delegates for today's webinar. It is going to be an interesting webinar because we are going to have a discussion on demystifying the ART law, that is the IVF law, ART law, and also the ANC management that we are going to have a talk on. So I also wish all of you a very happy Gudi Padwa, that is very auspicious occasion. And also now I request Dr. Aarti Nimkar ma'am, who is our president POGS, to give a welcome address to all the faculty and delegates. She is a senior member practicing obstetrician and gynecologist. Since can I have the CV of Aarti ma'am? Aarti ma'am. Ma'am, yeah. So she is practicing since more than 40 years. Ma'am's main interest is practicing safe motherhood with healthy babies. And ma'am has also practiced in Suman Nursing Home. She is an active POGS member since 2012. She has worked as a treasurer for POGS, and for MSR, she has worked as a Sahyadri Hospital or Authorization Committee Organ Donation 2022, 2020, 2021. She has been worked as a core committee in PMC in COVID pandemic. She has received various awards like Best Branch Award, IMA, Best President Award for National IMA, Dhanvantari Award of Lokmat 2021, IMA Pune Doctors Day Award, July 2023. So we are fortunate enough to have Dr. Aarti Nimkar ma'am, our beloved President POGS, with us in today's webinar. So I request ma'am to give her welcome address.
Thank you, Kanchan, for the introduction. It is, I think, very long. My work is very short. Yeah, I welcome you all, the delegates and faculties from the Ahmedabad Society and Baroda Society and Pune Obstetric Gynec Society. This is the Minu Child Brain Product Cutting Edge webinar since last 2 months. She's taking this every week on Tuesday. Her thought is very good to connect all the societies in India in every day, 2 societies or 1 society, and exchange of the thoughts and knowledge, and what are the new things we can see in every society we can share to each other. And it is a great project. Thank you very much.
Thank you so much.
Thank you, Aarti madam. And Kanchan, this time we are doing with Ahmedabad Society.
Yes,
yeah.
Society Ahmedabad
and Baroda. Yes, ma'am. So I request Prasad to please play inauguration prayer, a Ganesh Vandana that we have a ritual of. Mr. Prasad, please play the Ganesh Vandana.
Yeah, just a moment.
Yes.
Kurutvam kalyanam arogyam dhanasampadam shubham kurutvam kalyanam arogyam dhanasampadam shatru buddhi vinashaya deepajyotir namostute deepajyotir namostute shubham kurutvam kalyanam arogyam dhanasampadam shubham kurutvam kalyanam arogyam dhanasampadam.
Lilo Metler, but before I the introduction,
I would again like to welcome once again all the delegates, faculty, especially Ahmedabad OBGY Society, which is such a vibrant and dynamic society. And cutting edge webinar is brainchild Dr. Meenu Agarwal, like Aarti Madam said. And we solicit everybody's blessings and best wishes for Dr. Meenu Agarwal, who is the Vice President candidate West Zone for the incoming elections. So we really need your wishes because she is the best candidate. She's absolutely brilliant. She has done huge amount of academic work, a lot of work for Foxy, for imaging and teaching work also. So we are truly honored not only to have Dr. Metler as chief guest, but we have guest of honor, Dr. Parul Kotadawala and Dr. Mahesh Gupta, who are big names in Foxy. And we are truly honored and privileged, also with presence of Dr. Munjal, who will be giving the second talk, and Secretary of Ahmedabad OBGYN Society, Dr. Akshay Shah, Dr. Ashish Kade, who's our very own POGS chairperson, Foxy, Dr. Ashish Verma, and Dr. Parsha. So, talking about Lilo ma'am, as we all know, is a teacher of teachers. And she has taught, I think, half of India, or more than half, are all her students. And ma'am has inspired us to take up laparoscopy. And, majority of the gynecologists in India are doing very good laparoscopy work, thanks to Lizo ma'am. And apart from the highly academic achievements and the person she is, I think we all admire Madam's enthusiasm and energy, and the way she is so friendly. She mixes with everyone. She gives us advice. So it's truly an honor and a great privilege to have international faculty, international big-time personality, Dr. Metler, as chief guest. I request Madam to give her blessings.
Do I have to share the screen? Do I have to share the screen or just talk?
Oh, no, Lilo, you just have to give,
Okay, my dear colleagues, unfortunately, this little CV that was demonstrated shows only my last 15 years. Before 40 years, I've been in Germany and still active director of Department of Obstetrics and Gynecology, University Clinics of Schleswig-Holstein. We had 35 endoscopic courses of Indian colleagues every year, and one of the participants was Meenu Agarwal some years ago. Again, she came in artificial reproductive technologies as well as in laparoscopic surgery. So we had a lot of connection with India over the last 50 years. I'm already 85 years of age and have seen development in endoscopy. I think the two topics you've chosen of today, ART and safe motherhood, is a great achievement. For ART, I can say that I worked in 1976, about a year with Robert Edwards, and we developed at that time many, many things. The first test tube baby, was born only in 1978. In Germany, we had the first one, 1981. In India, Meenu, you tell me, I don't know. When did you have the first one?
Just after the first IVF baby, second was born in Calcutta in 1981.
Yeah, that I know with Mukherjee, with Subhas Mukherjee. I've known him quite well. But later on, you had some pause, and then you had another one. In when? When was the next one then?
88, Indira Hinduja.
88, yeah. Well, the time has advanced, and we are still with ART. We are lots more with endoscopic surgery and robotic surgery. And it was my pleasure today to do a robotic surgery in Mumbai in the center of my colleague Prashant Mangeshikar. With my friend Meenu Agarwal, we've been doing lots of surgeries and ARTs. So everything is working. I just want to give two messages for your topics. For ART, rules in ART. Laws have been established and need to be established. But unfortunately, at the beginning, we did not have any laws. And it took a long time till we were able to establish laws in every country. Sometimes laws are hindering us, but they are necessary for a good interaction. And we'll have a good lecture on that topic. For safe motherhood, I can say that only in 1987, I think it was really by WHO established that safe motherhood needs to be supported, particularly by the UN and so on. And today we see that we can do much more for safe motherhood for children and for mothers that are born and not have to die. So this is a very good topic that you have initiated in your conference. Every year, hundreds of thousands of women still die at childbirth. And that is something we have to really, really work at. And I think it's a good topic you've established for your seminar. I wish you the best of luck. And it's a pleasure to be with you and join you in India for my short stay of a week here. It is a pleasure to be with you. Thank you very much.
I just want to add one thing in Dr. Leo's CV. The Kiel School of Reproductive Medicine is now known as Lilo Mettler School of Reproductive Medicine. So, yeah, so a big round of applause for that.
Thank you very much.
Thank you.
Yes. So we are really honored to have such an international faculty with us for today's webinar. Now I request Dr. Charu Bapai ma'am to introduce our guest of honors today, Dr. Parul Kothawala and Dr. Mahesh Gupta.
Thank you so much, Dr. Kanchan. At the outset, a very happy Gudi Padwa, happy Ugadi, happy Chaitra Navratra. This day is known by so many different names all over the country, but it is a very auspicious day. And I pray to the Almighty that may Dr. Meenu Agarwal's all wishes, academic and extracurricular, be fulfilled in this coming year. And to bless her, we have none other than two extremely fantastic guests of honor today, Dr. Parul Kothawala and Dr. Mahesh Gupta, sir. It was a pleasure to meet Dr. Parul Kothawala. The first time you see, he's a very pleasant and quiet personality. And it's only when you read his entire CV do you realize the intense amount of work that he's been doing. Currently, he's the ICOG chairman and he's running the academic wing of FOGSI. So, sir, congratulations on your being installed and to the great work that you're doing for ICOG. He has been the guide for numerous dissertation theses, menstrual pattern and correlation. He's done the FOGSI Advanced Endoscopic Surgery Training Center at BJ Medical College since May 2000. He's a trainer for microsurgical techniques in tubal surgery. He's a trainer for LabTL, which is one of the most important family planning agendas of the government. He's been the peer reviewer for the Journal of OBGYN, the Jogi. He's a peer reviewer for Iranian Journal and the Dewhurst textbook of OBGYN. He has editorship. He's a member of the editorial board of Indian Journal of Perinatology and Reproductive Biology. I just was speaking with him and I realized that he's very closely associated with the perinatology and he promotes breastfeeding to a very large extent. And so I'm sure the breast committee will be very happy to be even more closely associated with ICOG, Dr. Kothawala. So over to you for your kind words and your blessings for the webinar.
Well, thank you very much, Dr. Charu, for kind introduction. I don't know from where did you download this because this is quite a dated CV. But anyway, thank you very much.
They don't want to disturb you, everybody to ask for CV so they manage on their own.
Must be at least 15, 20 years old. But well, it is indeed a pleasure and part of this webinar is my own home society. It is a joint program between Pune and Ahmedabad. So for me, it is my own place where I am sitting in Ahmedabad and talking to you all. Madam Mettler has highlighted all details about the topic, so I would not go into the detail. I still remember attending a European Society Gynec Endoscopy annual conference in Paris, where Professor Bruha came up on the stage and just mentioned two words. He said, I welcome you all and I declare the conference open. And then he said, I request the chairperson to take over the further proceedings. So I also, with wishing you all the best for this webinar, request the chairperson to take over and continue. Thank you very much.
Thank you so much, Dr. Parul.
Thank you.
Thank you for your presence. I understand that you are busy with another ICOG webinar also. So thank you so much for joining this webinar. Thank you. And now over to our next guest of honor, none other than Dr. Mahesh Gupta, sir. An extremely popular personality, extremely respected personality, And not only is he a leading gynecologist of India, but I think he too has a number of followers, a number of students, because his work on PPH, work in laparoscopy is extremely well known to all of us. His work on placental, problems. We have all heard him. We've seen him in so many conferences, and his talks are something never to be missed. He's the recipient of the Times of India Health Icon Award. He's been the former president of the Large and Vibrant Ahmedabad Society. He's been convener of the Gujarat State Gynecological Association of India, presented numerous papers in national and international conferences, and he has developed and patented the COMOC-MG stitch technique to control PPH. Dr. Mahesh Gupta, sir, we are really fortunate to have you today as our guest of honor for today's webinar. We would like to listen to you, Dr. Gupta.
I would also like to add that he is the chairman of the Gujarat Society of IAGE, and he is also the president of the Gandhinagar OBGY Society. Am I right, sir?
Yeah.
Fantastic person, fantastic human being. Whenever I call him, even if he's busy, he'll pick up the phone. I will talk to you later, and he'll keep the phone, but he'll pick up the phone. So that's very, very, very nice, and a lot of work behind you, sir, and lot of students, a huge fan club that you have, especially in management of PPH and pregnancy related problems. So thank you very much for joining, sir.
Yeah, thank you for so much kind words by Dr. Charu and Dr. Yu. Actually, some of my qualities I came to know by this kind of webinar only.
Sir.
But anyway, I wish all the best for Dr. Meenu, and I admire Dr. Meenu's canvassing, because Ahmedabad, some big shot, they also told me that you have to vote for Meenu, huh, Mahesh? Then I told him, I will definitely vote for Dr. Meenu Agrawal. So all the best for Dr. Meenu. And it's a pleasure to share this webinar with all my Ahmedabad colleagues, Parul, Munjal, Akshay, Ashish, all they are present. I'm lucky to have this my colleagues here on the webinar. And I always love to promote the infertility or IVF related the webinar or conferences, because if they will flourish, then my high risk obstetrics will flourish. So I'm depending upon them for my obstetrics. So anyway, thank you for inviting me, and all the best for your future endeavor, Dr. Meenu, and all this Dr. Charu and Vaishali. Thank you very much.
Thank you so much, sir. Thank you very much. Thank you.
Thank you for your presence, sir. Thank you. It means a lot to us. Thank you for blessing our webinar. Yes. So with that, we declare that this inauguration function is over. We thank our chief guest, Dr. Lilo Mettler, and our guests of honor, Dr. Parul Kuddawala and Dr. Mahesh Gupta, for sparing their valuable time. And we move ahead with the scientific session.
Yes. So now I would request Dr. Meenakshi Deshpande ma'am. She is the General Secretary POGS. She was a past president of IMA 22-23 to introduce our chairpersons for the first talk by Dr. Meenu Agrawal ma'am, Dr. Akshay Shah and Dr. Ashish Kale. So I request Meenakshi madam to please introduce our chairpersons, Dr. Akshay Shah and Dr. Ashish Kale, sir.
Yes. Good afternoon, everybody. As a General Secretary of POGS, first of all, I'd like to welcome all the dignitaries on today's webinar. Professor Dr. Mettler madam, Dr. Parul Kuddawala and Dr. Mahesh Gupta. So thank you very much for coming on this dais of POGS. And now we will go on to our first session of demystifying ART law. We are having our first chairperson, Dr. Akshay Shah. So welcome, Dr. Akshay Shah. Is the Honorary Secretary of AOGS as Ahmedabad Obstetrics and Gynec Society. He is also the Associate Professor of SVP Hospital in the National Municipal Medical College, Ahmedabad. And his area of interest is high risk obstetrics. So welcome, Dr. Akshay Shah.
Thank you, madam.
Yes. As a chairperson, do you want, we'll introduce the second chairperson, Dr. Ashish Kale. He's from our own alma mater, POGS. He is director of Asha Kiran Hospitals, Pune. Is Family Welfare Committee chairperson of Foxy 2325. Is the clinical secretary of ISA 2224.
Sorry
And
to
a second-
interrupt, ma'am.
Yeah.
So we are running out. So sorry to interrupt.
We will
So-
just go fast here.
Yeah. So-
And he is a recipient of Skill Excellence Award 2023. Is also V for Stree Amox Award by Governor of Maharashtra. And he's got many awards and credit to his credit. So welcome Dr. Ashish Kale
Thank
to
you.
our
Thank you very much.
webinar. Yeah, as a chairperson. And now I wish that we'll go forwards. I myself been working in the medical legal field since last 15 years and more so since last 5 years. And this ART law and changes in ART law has been my topic of talks, which I give in many other societies. So thank you, Meenu madam, and thank you, Vaishali, for giving me a choice of introduction over here. And yes, we'll go on to the ART law, over to the chairpersons for the introduction of the speaker, Dr.
Yes.
Meenu madam.
Yes. Okay. May I request Dr. Akshay Shah sir to introduce our today's speaker, Dr. Meenu madam?
Yes, madam. Yes, madam. Thank you so much, Pune OBGY Society and the office bearers for this wonderful webinar and including us as a chairperson. I would like to introduce our first speaker. She actually doesn't require any introduction, but still just enumerating few points about her. That is immediate past president of Pune OBGY Society, elected Secretary General International Society of Gynecological Endoscopy. She is a course director in endoscopy and ART training courses in UAE. She has over 12 publications in international journals. First author for 4 books and authors many other chapters. She is Bachelor in Reproductive Endoscopic Surgery, European Board certified. She has been awarded with India's Greatest Leaders by Asia One. She is awarded with Icons of Health by Times Group and Foxy Champion of Foxy Award. So I request Dr. Meenu Agrawal to go ahead with her speech. Ma'am, stage is yours.
Thank you. Thank you, Dr. Akshay Shah, for this kind introduction. And thank you for the Ahmedabad Society to join POGS today to have this particular mixed bag kind of a session, which is on ART bill and then joyful motherhood. So now going to the ART bill. See, first thing is that we have to understand that it is on, and I'm very happy that Ashish is there as a chairperson, and also Dr. Meenakshi Deshpande is there, who also is a medical legal person, of course, with Dr. Akshay Shah. So, and Amol is there, so you can guide me, or we can always answer the questions if something we get stuck somewhere. So when I talk about the ART rules and regulations, the final draft came in on 25th of January 2022. It is called ART and Surrogacy Bill. Now, what they have done, main thing is they have divided into 3 parts. The entire ART industry or ART segment, you can say. Industry is not the right word to use. So ART clinic, ART bank, and surrogacy clinics. So these are the 3 parts they have divided. Everything has a special fees. Whatever you register for, you have to renew it maybe after 3 years or 5 years. Depending on the level you are registering, you got to have a mandatory staff. ऐसा नहीं है कि we can just have 1 or 2 people and we have a ART level 2 clinic. So they have mandated what we can have. There is a defined functions, and the worst or the whatever, there is also a punishment associated, and very harsh punishment if we don't comply with the law. So when we talk about the eligibility criteria, so now it is commissioned by married couples or women. Okay, a single woman or a divorced woman also can go for a ART. The woman should be between 25 to 50 years of age, and the man should be between 21 to 55. However, for a single woman, the age is different, which I will come to later. And this married couple, they should have infertility issues. I mean, they just can't say, I want to do ART because I don't want to carry we don't want to try naturally, or there should be some proven medical condition jiski wajah se they are not able to conceive. तो how is it different? ये 2022 में आया है. What happened in 2019? They said Indian couples. That means they excluded all foreigners in this law in 2019. And then there were petitions, there were changes. So they came to, then now is the commissioning couples. Okay. So the Indian word is removed. They said the woman should be between 23 to 25, which again now is changed between 21 to 50. The man should be 26 to 55, which again, with good wisdom of people who were sitting there, who worked very hard and who actually went to them without any greed. For general public, that this is not the right thing, this should be changed, and now it is male between 21 to 55. Then they initially said that they should not have any surviving biological, adopted or surrogate children. Now, किसी को एक baby है, they want a second child, so that again it was changed and that line was removed in the 2022. However, this remains for the surrogacy still. Then they said that every ART clinic and every ART bank, ये दोनों we should register under the National ART and Surrogacy Registry, right? And this registration will be valid for 5 years. So initially 2019, they said every 3 years you have to renew. So and then they updated it, and now it is valid for 5 years. However, surrogacy is valid, surrogacy license is only for 3 years. So what they did, they made 2 boards. One is a national board, one is a state board. National board, they have people in the national board from all stratas of the society, in the sense from the political bodies and the bureaucrats and the doctors, and they will advise the government on the ART related policy matters. अभी डोनर, अगर हमको डोनर एग लेना है या डोनर स्पर्म लेना है, so for the sperm it is age is 21 to 55. No, you cannot take a donor sperm मतलब कहीं से भी. It has to come from the donor bank which is registered with the state or the national board. And for the lady, for the woman, it is 22 to 35. The woman can donate eggs only once in a lifetime. All of us ART consultants have gone through that phase where the, donors would have donated like almost every alternate months because of the financial reasons. So all that has been removed, and this has to be registered in the national grid, so that that lady who's donated eggs once at ABC center somewhere sitting in Timbuktu also cannot donate egg in another center, because her data is already gone to the national board. Then a single donor cannot give that sample to more than one commissioning party. So semen sample ya eggs, they should go only to one party. Again, we have to have the consent from the both the recipient and the donor. Clinic has to check for any genetic diseases. All the infection screening has to be done. And of course, sex selection is absolutely capital N and capital O. Huge penalties, not only for selection of the sex, but even talking about it. So that is absolutely no. Now, suppose कोई अपनी sister का egg ले लेता है, because now in this particular law it is allowed, but the child who will be born will be biological child of the commissioning parents. So whoever has donated the egg or given the sperm, of course we don't know, it is anonymous. They have no right over the child, and even from the surrogate mother. So अभी clinic and bank दो अलग-अलग हो गए. बैंक को क्या करना है? बैंक हैज टू register the donors. Okay. And for us, it is again in 2019, they said you need to keep all the records for 25 years, which is like a huge data that you have to carry. Now they said you have to maintain records of all donations for 10 years, after which these records will be transferred to the national registry. I'm sure everybody knows that in UK and in some other countries, the child has a right after he or she becomes 18 years of age that they can find out that who the donor egg or donor sperm, who was the donor. So I think that that is why this particular law has been put here. The point has been put here. And of course, all this, we cannot exploit the couple, the woman, the donor, and punishment is 5 to 10 lakhs. First time, agar pata chala, because there are some, they want to remove all the centers where the practices are not very good. Perhaps, I don't know. But and agar if second time if it happens, then it also has a jail and a fine. But one good thing that they have done, that the court, they can only go to the court if the complaint is by the national board or by the state board. So first state board and national board will check, and if there is a complaint by them, then the court will take action for these offenses. Now surrogacy has to be जिसको surrogacy करनी है, that person has to be an Indian citizen. Couples, of course, also for a woman, she can be single or divorced. No embryo freezing, I did not understand, but it is there in the book. The surrogate has to come from friend or family. Any friend is a very vague term, but yes, and there should be no commercial thing between the surrogate and the commissioning couple, and the medical insurance of surrogate should be done, which is a very, very good thing. Now, there are 3 types of clinics. एक क्लिनिक में क्या है, हम लोग सिर्फ उसको लेट्रोस दे रहे हैं, हम सिर्फ उसको अल्ट्रासाउंड दे रहे हैं. And we are telling the couple, okay, this is the right time, I'm giving you HCG, now you should have intercourse so that your fertility period is confirmed, or you go for a tubal testing, or you go for a semen analysis to another lab. So here there is no handling of sperm, egg or embryo outside the body. So these particular clinics are primary infertility clinic, and they do not require any registration. Now there is another thing which is called an insemination. One is IUI and one is insemination, right? जिसमें इंट्रावेजाइनल, वो हस्बैंड का सीमन लेते हैं एंड उसको सिर्फ सिरिंज से वेजाइना में प्लेस कर देते हैं. Now whether that comes into primary infertility clinic or ART1, it is little unclear, but I would still suggest that it is better to register to ART level 1 if you are handling any kind of semen outside the body. So here all IUI with husband sperm, IUI with donor sperm, all are included. That is ART level 1. इसमें आपको 50,000 rupees पे करना है. ART level 1 के लिए आप रजिस्टर कर सकते हो. You have to have I will tell you what all you require for this particular thing. एक gynecologist, of course, you are there. Then microscope, centrifuge, refrigerator, and then 50,000 rupees you have to pay, and this should be renewed every 5 years. So this is all that is required. Then we have the level 2. Now level 2 में क्या क्या चाहिए? Level 2 में आप सब कुछ कर सकते हो, but not surrogacy. Okay, मैंने surrogacy भी कर सकता हूँ. You have to take a separate license for surrogacy. तो gynecologist, anesthetist, embryologist, counselor, director is optional. And again, जो नए खोल रहे हैं, जो already existing है, they are getting their registrations done. They can get their registration done, but the new centers which are opening, there the doctor should have a record of performing 50 ovum pickup procedures under the supervision of a trained ART specialist. And don't take it lightly, because this is a very, very important point, and one fine day somebody may come and ask for a certificate, so that has to be there. And again, they can have a DM, they can have a FNM or FNB or a MCH in reproductive medicine, or they have at least 3 years of working in an ART level 2 clinic. काउंसलर को या तो साइकोलॉजी ग्रेजुएट इन साइकोलॉजी, शी कुड बी इन क्लिनिकल साइकोलॉजी, इवन नर्सिंग, which is very good because some nurses are really can become good counselors, or any life sciences, any BAMS, BHMS, BUMS, somebody who's a graduate in a life sciences degree can also become a counselor. अभी level 2 में क्या क्या चाहिए? I mean, all ART consultants here, so microscope, incubator, laminar air flows, but thing, if you look at this, they have not mentioned a micro manipulator. So you can have an IVF clinic without an ICSI machine and it can still get registered for level 2. And here you have to pay 2 lakhs rupees where you have to renew it every 5 years. If you want to add a surrogacy, same level 2, same whatever you have, you will have, but you want to also register for surrogacy, then you pay 2 lakhs more, and surrogacy license has to be renewed every 3 years as against this, which is every 5 years. Thank you, Amol, for telling me that. Then every clinic should have a grievance handling. वो बाहर बोर्ड ही लगाना पड़ता है पेशेंट के लिए कि एंड उसमें यू हैव टू पुट 3 names. You can put it from your clinic, your accountant or your counselor. 3 names should be there, and there has to be a cell, and एक form है patient complaint form which should be available at the reception desk. So वो check करते हैं, तो that should be there, and patient should have an option of complaining. Of course, selling, purchasing, abandoning, disowning, all that has a huge fine, which is good that it is come into the regulations now. अभी कैसे कैसे ओव्यूलेशन इंडक्शन कौन कर सकता है? अगर हमको ओरल टैबलेट्स लेट्रेजोल देना है, क्लोमिफेन सिट्रेट देना है, तो एनी गायनेकोलॉजिस्ट कैन गिव विदाउट एनी रजिस्ट्रेशन अंडर ART law. Right. However, if you want to give either oral agents or gonadotropins followed by IUI, then you have to have level 1 ART registration. But if you want to do a controlled ovarian hyperstimulation or stimulation for an IVF cycle, it should be at level 2 ART clinic. पहले क्या करते थे वो, मतलब वी वर ऑल्सो वेरी हैप्पी कि कोई स्टिमुलेट करके आप भेज दो, हम लोग पिकअप कर लेंगे. However, this is not allowed now, and we have to be very, very mindful of this law that you have to stimulate the center at your center. Now, suppose मेरे पास कोई पेशेंट है, she wants to do surrogacy. I want to send her to Amol कि तुम कर दो surrogacy, मुझे my center is not recognized. But I cannot stimulate her at my place. So that is again a law that if a patient is going for surrogacy, she should be stimulated at a place which is registered for surrogacy. So that is again a very, very important law that we have to keep in mind. अभी किस एज में हम what we can give? Now suppose हमको letrozole देना है, 18 years and above we can give letrozole, no problem at all. But suppose we want to do IVF, then it has to be from 21 years up to 50 years. Oocyte donation for a donor, the age should be 23 to 35. So I hope that is clear. For donor, for the egg and surrogate also, same 23 to 35. उसी के बीच में आप उसको surrogate ले सकते हो या donor ले सकते हो. Donor and surrogate both can do this only once in their lifetimes, whether she is doing surrogacy or she is doing egg donation. Oral agents you can give from 18 years, no problem. However, they have not mentioned whether you can give gonadotropins. 18 years and 19 years, PCO hai, she wants to conceive. Can we give gonadotropins? It is not mentioned here, but I suppose it should be permitted. अभी ART बैंक का क्या काम है? ART बैंक we will register, then they will screen the oocyte donor. They will screen for HIV, HPS, AG, SCV, VDRL. And as I said, अभी ART बैंक 2 हैं. One is Semen bank and one is oocyte bank. Oocyte bank में the stimulation will be done at the ART clinic level 2. In the semen bank, the semen will be stored in the semen bank. So eggs are not stored in the ART bank, in the oocyte bank, right? Oocyte bank will only screen the donors, सब तैयार करके they will live उसका जो भी insurance, health insurance वगैरह करवा करके they will send her to you with all the details, right? And then you should try to remove she should be stimulated in such a way that you don't get more than 7 follicles. However, if you have more than 7 follicles, then this line was also added later on. The clinic shall retrieve all the formed follicles. Now, this is a new line which they have added. Somehow I was very, nobody was happy that oocyte donor now can be familiar to the commissioning couple. So just imagine that she'll say, I'll get my sister, and it is allowed. So that is something which is little difficult to understand, but this is the law. So even if a patient says, I want my sister to become my donor, the sister can go to the ART bank, register herself, and then come to the clinic and then donate her eggs. Now we know who the donor is. The recipient also knows who the donor is. Her sister is the donor, but they said कि इसमें only 5 parties should know. एक तो donor को पता होगा, ART clinic को पता होगा, ART clinic में जो भी है, ART bank में जहाँ पर register हुआ है उसको पता होगा, commissioning couple को पता होगा और national registry वालों को पता होगा क्योंकि हम वहाँ पर भेज रहे हैं. So that means the whole world knows about it, but still it is kept confidential. So something like that. Again, I'm sorry. So we cannot pay money to the donor, but she can be compensated for food, travel, loss of wages, insurance cover for 12 months, and जिसको उसे डोनेशन लेना है, the intending couple, they should sign an affidavit in front of the, और ये registered notary can also give. So most of the work, there are people who can do this work for you. This we already discussed that we can do it. Again, अगर सरोगेसी करना है, married है, तो 23 or 50 years के between these ages. However, if it is a widowed or divorced, now here single they have removed, widowed or divorced, between 35 and 45. So I thought this is a very intelligently thought of. Okay, 35 se pehle she can still find a partner, and then the child may not be accepted by the partner, and 45 rakha instead of 50 because she's the single one handling the child and she does not have a partner. So there are no two parents to handle the child. So I think 35 to 45 is a very good thought of age that has been. That is allowed, so that is not a problem. Now, there are consent forms. Oh my God. If we talk about the consent form, they are huge. So there are actually these many consent forms. So I have just written a book on ovulation induction. And these consent forms are actually slightly again revived or, with all the legal language by Dr. Dilip Palke and Dr. Samida. So both of them have done this consent form chapter very well. So if you get time or if you want, you can download all these forms and then use them. And I keep getting some inquiries ki iska form chahiye. So I actually send these consent forms to them. There is even a consent form for information on diminished ovarian reserve. So if the patient has a poor ovarian reserve, you're going in for a donor egg. So there is a form which you have to take a consent that she's explained that she has a diminished ovarian reserve based on ABCD, and that is when you can go for the next level of the treatment for her. So again, these are various forms that are there. So I will not go into the detail. And as I said, now registration, existing clinics kabhi bhi kar sakte hain. New clinic karna hai, so I already told what is required, the number of egg pickups and whether you have done a FNB and all of that is required. And basic requirement we again already discussed. All this is required. Very important is a proper semen collection room, proper semen processing lab, a record room is again they have added, storeroom they have added, and I'm sure people living in Bombay, even in Pune, sometimes you're always struggling for the space. So the sterile area, lab, ऑपरेशन थिएटर, देयर इज अ रूम फॉर एम्ब्रियो ट्रांसफर. से नॉर्मली हम लोग क्या करते हैं, ऑपरेशन थिएटर में एम्ब्रियो ट्रांसफर करते हैं, बट व्हाट दे हैव मेंशन्ड इज देयर शुड बी अ रूम फॉर एम्ब्रियो ट्रांसफर व्हिच शुड बी सेपरेट. सो दिस आई ऑलरेडी डिस्कस्ड. एंड power backup, again 2 types of power backup, either you should have a UPS or you should have a generator in level 2 and level 2 clinics. So that is again very, very important that this should be there and it should be also mentioned. Now donor ka age should be 21 to 45 for sperm donor. Now ये sample आपको semen bank से ही लेना है. You have to match, you send them the details. The sample should be, the gentleman should have done an infection screening, say today, then 6 months, not 3 months, 6 months after he is given the sample again, and then the sample should be dispatched. Oocyte donor, again we discussed the age between 23 to 35 and the infection screening should be done. Surrogacy, again we have already discussed. Now अगर कोई surrogate mother को आपको deliver करना है, so don't admit her in the name of the commissioning mother. Admit her in her name. कल को something happens to her, then who's the patient? The name, you cannot change the name. However, when you're discharging the baby on the birth certificate, the name of the commissioning parents or the commissioning mother can come on the birth certificate of the baby. Counseling again is very, very important. Confidentiality, grievance cell, that all has to be done. Renewal, as I said, 50,000 for level 1, 2 lakhs for surrogacy, and 1 lakh for the ART bank. Suppose आपने अप्लाई किया आपके सेंटर को कि I want to register as an IVF center, it gets rejected. If it gets rejected, you can again appeal to the state board, and the state board has to reply within 60 days of thing. This is the website that you can go for. You can take a picture, or you can go on this website and you can click, and it is very easy how to apply on this. When I was looking at today's data was that, so many, 1 minute, let me see if I can, 1 minute. So many people applied for this. Okay. Yeah. So 1422 applications received, 113 register हुए हैं. इसके I think this picture is not coming, but I will tell you the exact number later on. इतने surrogacy clinic की application है 170 है. This is also about plus 1,000 and about 600 odd ART clinics have been registered. Reject कोई भी नहीं हुआ है so far. No, zero rejected. So there has been no rejection as of now, today that I checked on the website. And so this was all about the ART bill, what I could understand also. And if there are any questions, I think I have Amol, Ashish, and I have Minakshi, so they can help me to answer if there are any questions. So thank you very much. Thank you so much. Thank you.
Thank you, Dr. Minu Agarwal. At the outset, I'm really thankful to Dr. Vaishali Chavan for calling me up for this webinar. Brilliantly narrated the ART law, because it's an ongoing process. Being on the board of ISAR as a clinical secretary, we had been to several times to the government to change this particular things in IRT law. Rightly said by you, the level 1 and level 2 has a different implications and different services to offer to the infertile couples. But saying so, the surrogacy clinic, when it's going to get registered at the ART bank, you need to be a documentations is a key, because if you are filling in your documentations for the donor program or for that matter ART bank, then it is liable for the actions. So Minu, brilliantly done the job of yours as a ART law and ART specialist in the country. And I'm really wishing you all the best for your future endeavor in Foxy, because being a true friend and we started our journey in the same path. I wish to see you on that particular post in Foxy.
Thank you, sir. Thank you so much.
So one question is there for you, Meenu. Can I ask? Is Meenu over there?
Ma'am?
She's not there. I think there is a problem.
Yeah, maybe. Ma'am, I think we can keep a question answer session at last. Is it okay? We will continue forward.
Yeah, if she's not there,
Yeah.
we'll continue.
Yeah, we will we'll keep
Yeah.
question answer session after the next talk, ma'am. Now I request Dr. Amol Lunkad sir to introduce our next chairperson, Dr. Ashish Verma and Dr. Parth Shah from Ahmedabad Obs and Gynec Society. Our next speaker is Dr. Munjal Pandya sir. So I request Dr. Amol Lunkad sir. Sir is a clinical secretary. Yes. Of POGS.
Kanchan.
Yes.
Yeah, good evening, everyone. At the outset, let me welcome you all on behalf of Pune Obstetric and Gynec Society. And I thank Ahmedabad Obstetric and Gynec Society for being with us today for this cutting-edge webinar. And it's my proud privilege to welcome our chairpersons. Dr. Ashish Verma is an assistant professor, Narendra Modi Medical College, Ahmedabad, a fellow in minimal access surgery, diploma in minimal access surgery, and fellow in from the International College of Robotic Surgery. So we have a endoscopic surgeon here to chair this session, and along with him we have another chairperson, Dr. Parth Shah, again from Ahmedabad. He has done his fellowship in gynae endoscopy and is a consultant, Seva Rural Hospital. He has done his observership from the Fetal Medicine Foundation, UK, and he has done his diploma in gynae endoscopy from France, consulting endoscopic surgeon and fetal medicine expert. So over to the chairpersons for this next session on joyful motherhood.
Yes. Yes.
Yes. Thank you, madam. May I take the lead from now here? Yes.
Yes.
Thank you, Meenu madam. Thank you, Dr. Kanchan. And this was a very nice welcome. And it's very nice to be associated with Gynec Society. The next speaker is Dr. Munjal Pandya. He is, I don't need a CV to introduce him. Actually, he is my associate professor here in the same college. And we are actually in the same unit. And again, Dr. Akshay is the secretary. Munjal sir is he is treasurer here in the Ahmedabad Society, and he was past secretary Ahmedabad Society, and has co-authored many books and has been to many conferences in national and state-wise. Also authored even a literature book. He is in Gujarati and is very fond of music also. Other than the other hobbies are also so much there. So we'll proceed with Dr. Munjal sir on the with his talk on the intrapartum care for joyful motherhood. Thank you, madam.
Thank you so much. Thank you so much, Pune OBGYN Society, Vaishali madam, and Dr. Kanchan madam, and Dr. Ashish for the kind words of introduction. The topic for the day is intrapartum care, that is for joyful motherhood. This is something where we can actually discuss upon a lot. I'm not going to take a unidirectional lecture. I hope that we'll be having some discussion with regards to this. This PPT is something which I have received because I did not have time to make my own in a couple of days. So it has some papers being quoted, and with regards to program labor, which is actually right of every pregnant female. So to begin with intrapartum care, I would say that it is something which is actually right of every antenatal female who is undergoing vaginal birth. We would try to avoid, for example, using terms like normal delivery. So yeah, this concept has basically three pillars majorly. The first one is pain relief with the use of analgesics and antispasmodics. The second one is adequate uterine contractions with the use of active management of third stage of labor, which has its own components as well, which we all are very well aware of. The third part is close clinical monitoring of labor events in form of partograph, or we call it as partograph. So these are the things which would yield optimal outcome with regards to the maternal and fetal or perinatal outcome. Again, at the same time, having less painful memories of that whole process of labor with regards to mother herself. So active management of third stage of labor was a concept devised by Irish School. In 1973, O'Driscoll and colleagues reported advantages of AMTSL, that is active management of third stage of labor, in the form of shorter labors, improved obstetric outcomes, and lowered cesarean section rates. Nowadays, we are calling it as optimization of cesarean section rates with regards to reducing the rate or having optimal outcome in form of mother as well as baby. Why do we need active management? Because at times that we know that it is something which would have a monitoring or intrapartum monitoring with regards to fetal heart rate, with regards to number of per vaginum examination, with regards to status of mother. So in a way, it would help in prevention or reducing the chances of infection, maternal dehydration, because we'll be having the charting of input and output in form of input of IV fluids and oral fluids along with the urinary output. It would avoid, or most probably it would actually have pleasurable impact rather than having exhaustive impact of the whole process of labor. Dissolution in mother will be avoided because the pain component will be reduced. It will be avoidance of ketosis as well, and fetal distress or abnormality of fetal heart rate will be avoided most of the times because we'll be able to have a check or monitoring of fetal heart sound. Partograph, this is an old one. We know the WHO modification of partograph, and to quote ACOG has, just a second. ACOG has, hello. So basically, ACOG has come up in the year of 2016 or 17 in form of 6 being new 4. So nowadays we know that 4 centimeter is not something which is used as demarcation for active stage of labor. 6 centimeter is something which would regard as active stage of labor, and before 6 centimeter it might be latent phase of labor. So definitely plotting a partograph would be a different experience after that particular suggestion from ACOG, which is now widely accepted in India as well. So when we talk of partograph, it is something which is having all the maternal and fetal components. Maternal component would be having cervical dilatation and descent of head, along with the infusion or IV fluids, the amount of IV fluids and which IV fluids, along with the oxytocics, are being administered. The fetal component would be something which would be having this, the meconium. Thank you. So meconium, whether there will be leaking or intact membrane, whether there will be meconium stained liquor, whether there will be adequate uterine contractions or number of uterine contractions. So this whole partograph is something which would actually avoid a lot of mishaps, or which will actually reduce the chances of maternal and perinatal complications. So which are the mothers which would be offered as a program labor? So no identifiable or medical or obstetric complications, will be there in those mothers who are subjected to program labor. Primary gravida patients with singleton pregnancy with cephalic presentation and spontaneous onset of labor. Again, a few of the criteria where we would be able to define normal labor. Gestational maturity of 37 to 41 weeks. Admission NST would be reactive. We know what is a reactive NST, having at least 2 acceleration, bit-to-bit variability, and no deceleration. Active phase of labor with cervical dilatation 4 and beyond centimeter, and at least 50% effacement of cervix. So these are the patients who would choose to have a program labor protocol application. So primary or multigravida more than 38 weeks, gestation, low risk patients having no other comorbidities, presence of anesthetist would be required along with a neonatologist. Consent of mother and relatives will be of utmost importance, with explanation of the protocols that we are going to administer. And it has to be given, or it has to be started at after the active phase of labor. So who are the patients who will not be given this program labor protocol? So the patients having high risk pregnancy like antepartum hemorrhage, pre-eclampsia or eclampsia, gestational diabetes or even overt diabetes during pregnancy, polyhydramnios or oligohydramnios, cephalopelvic disproportion, malpresentation, and pre-labor rupture of membranes. Now, these are the patients who are not to be subjected for program labor. The medication protocols for intrapartum care begins only when the patient enters active phase of labor. The starting point of active phase of labor is identified on basis of cervical evaluation, which is at least 4 or beyond centimeter of dilatation and effacement more than 50 centimeter, adequate uterine contractions, that means at least 3 contractions per 10 minutes, and each one lasting for at least 30 to 40 seconds. Head should be engaged, that is one of the criteria in cephalic presentation. There should be no clinical suspicion of CPD, and patient may have show or even leaking in active phase of labor. The medications which are used and which are enumerated are taken from Suffolk paper, which was published in 2009 by Daftari sir and et al. I'll go in detail with the next slides. What are the advantages? It actually provides benefits of drug synergism while at the same time restricting the complications related to drug with minimal amounts of, achieving progressive labor, at the same time allowing mother to be conscious, reducing the pain component, and that again would increase the cooperation from the side of patient with regards to intrapartum phase of labor. So to begin with, intravenous infusion of ringalectin 5% needs to be started at 20 drops per minute. Ensure that pains are optimal, that is adequate uterine contractions, at least 3 to 4 uterine contractions per 10 minutes, each lasting for at least 30 to 40 seconds. Then we can add 2 units of oxytocin to the drip, and uterine contractions are to be monitored accordingly if the patient is not having adequate uterine contractions. Now, the protocol in 2009 publication mentioned a usage of pentazocin or Fortwin 30 milligram, which is now not available. So there are people who are still using program labor protocols, but with the usage of ketamine, which again will be mentioned in the next slides. But diazepam is something which is usually avoided in the intrapartum phase and can be taken or used in postpartum phase once the baby is delivered. So I'll just skip a few of the things with related to Fortwin, which is not available. So this is original program labor, where the minimal dose of Fortwin was used without any side effects, without any neonatal and maternal side effects. It was published, and I talked with Daftari sir as well. He mentioned that mother was able to endure pain, experience lesser pain with increasing cooperation. And again, there was no sedation, like a patient would, be not able to talk with you. Patient will be continuously having conversation with you, even with her relatives, and at the same time will cooperate with reduced amount of pain, so that it will be having a nice experience of labor process throughout. And that again increased the optimal outcome in form of mother as well as baby. So the progress of labor was monitored in form of partograph, and when patient entered advanced labor, fetal head pressing down on the pelvic floor, patient starts complaining of severe pain or bearing down sensation. At that time, at around 7 to 8 centimeter of cervical dilatation, ketamine could have been administered according to the case. So anesthesia during labor is something which is practiced since long, right from the publication of this particular paper. The proven obstetric analgesia is epidural analgesia. In places where epidural is not available, tramadol could be used. And ketamine again is a dissociative anesthesia. In sub-anesthetic doses was found to be very much effective in reducing pain, along with the preservation of sanity or conscious status of mother. These are the levels which will be reflected upon in form of statistics in comparison in next slides. So now this is with regards to tramadol. So basically, it was used as 1 milligram per kilogram body weight intramuscularly, along with antispasmodic, that is rotavirin 40 milligram. Again, there are other options as well. The labor process was observed in form of partograph, and when, if required, ketamine was administered. It was administered in dose of 0.25 to 0.5 milligram body weight. It was diluted in 10 ml of saline and administered slowly over the period of few minutes. And if required, the doses could have been repeated after 20 to 30 minutes in form of half of the initial dose. So obviously, it would be like 7.5 to 15 milligram in patient weighing around 60 kg. And last top-up dose could be given after delivery of baby, so that the patient would be having relaxing status, along with allowance of all the vaginal and post-speculum examination if required. So clinical evidence, again, the study from Suffolk had the tables, which were actually reflective of quite a significant difference between the study group and control group. So vaginal delivery was higher in study group, which had program labor, 88% patients had vaginal delivery as compared to 81% in control group. Low forceps assistance was minimum with regards to the study group. Ventouse assistance again was a little higher, but again, the complication rate with related to baby was quite less as compared to the controls. Cesarean section rate was quite low, that is 12% in comparison to 17% in controls group. The mean duration of active phase was 3.5 hours, while it was higher in form of beyond 5 years in controls. The mean rate of cervical dilatation was quite faster in study group, that is 2.5 centimeter per hour, as compared to 1.2 centimeter per hour in control group. The mean duration of second stage of labor was 26 minutes as compared to almost double, 48 minutes in the control group. The mean duration of third stage was approximately 3.5 minutes, while in comparison with the control group, which was 15 minutes. The pain relief was significantly higher in case of study group because of the medications used as compared to the control groups having no medical assistance or analgesic effect. So significantly, the study group had a higher end with pleasurable labor experience as compared to the control group. So the rate of cervical dilatation was quite significantly higher in case of study group. The duration of stages of labor was significantly less as compared to the control group. The pain relief score was significantly better in cases as compared to the controls. And the complication, yes, complications were a little, not significantly, but still higher in cases group because the medications used had their own complications, which were not significant, like nausea, vomiting, and drowsiness were a little bit noted in few of the cases as compared to the control group. But again, they were not in a range to compromise or bring in any kind of respiratory or neurological depression in mother as well as baby. So basically, the results said that cervical dilatation was faster in study group. The duration of active phase was significantly lower in study group. The duration of second stage, again, was lower as compared to control group. The majority of the patients were delivered vaginally and cesarean section rates were quite less in study group. The pain relief was significantly better in study group because of the drugs used, and few of the complications were there with regards to side effects of medications used, but they were not significant and did not have any depressive effect on mother as well as baby. And there were no other, compromise with regards to fetal outcome in either of the group. So this is a chart or a graph, funnel plot, we call it, reflecting upon usage of antispasmodic, which actually showed that antispasmodics reduced duration of first stage of labor by approximately 74 minutes. So that was again something which had to be taken into account. So when it comes to comparison of antispasmodic, they had mid duration, significantly lowered in first stage of labor. In second stage as well, there is significant reduction in duration of second stage. And in third stage as well, it was reduced significantly. So total duration of labor was reduced with usage of antispasmodics. Again, there was comparison with regards to nulliparous females and multiparous females. A single dose of 16 milligram of valethamide bromide, we call it as epidocin, was administered via intravenous route in 35 patients, nulliparous patients, and 37 multiparous patients. The median time for complete cervical dilatation to delivery was 20 minutes in groups who received valethamide bromide, and 25 minutes in groups that did not receive valethamide bromide. So there was a significant reduction in the mean duration as compared to the patients who did not have antispasmodics administered. So median time from complete cervical dilatation to delivery was significantly lower in those having antispasmodics in nulliparous as well as multiparous. So side effects, again, there was not much significant difference in side effects. Yes, the patients who did not receive valethamide bromide had rise in a few of the side effects in form of tachycardia and dry mouth, which was not much experience in patients having valethamide bromide. So again, significance of side effects experience is not much there. So what are the adverse reaction with regards to usage of hyoscine and valethamide bromide? Again, no statistical significance was found with regards to adverse drug reaction when the age groups were compared, like 18 to 25 years and 26 to 34 years. So both the age groups did not have or did not show any significance in experience of side effects, and therefore ADR reported were irrespective of the age, and no life-threatening or severe forms of ADR were seen with regards to usage of hyoscine and valethamide bromide. So again, drotaverine hydrochloride versus valethamide. So when it came to comparison of side effects, headache was experienced in patients having drotaverine, and it was there again. It was not there in valethamide group. cervical tear was significantly, more in the group who received rotavirin as compared to the welathamide bromide group, which in those cases, only 3 of the cases experienced cervical tear. Again, the significance, clinical significance is not much with regards to the comparison of both the groups. So advantages of intraoperative monitoring, it actually comes in with shorter labors with substantial pain relief, again giving a little bit of better experience, and patient being fully conscious throughout the process will be able to remember all the events and will be a little bit of pleasurable experience, because throughout the process, patient would experience all the stages of labor. Significant amnesia of painful events of labor. So that is again one advantage with regards to usage of ketamine. Again, epidural analgesia in form of 0.0625% of bupivacaine along with fentanyl can be used, that is 50 microgram, which again would be having similar effects. But in epidural, a little bit of cooperation from the side of patient and education will be required. In case of those program labor cases, the blood loss, average blood loss will be less because monitoring will be constant, and at the same time, patient cooperation again will be there. So there will be lesser intervention in form of operative vaginal deliveries. The duration of all 3 stages was markedly reduced. Obstetric management was simplified, and monitoring was present throughout, and that again would be having optimal outcome. Again, at the same time, would be having lesser chances of future litigations as well, because we'll be having on paper records of all the events that the patient had undergone along with our efforts. Lowering of incidence of operative deliveries and neonatal morbidity was similar to the control group, so there was no depressive effect with regards to usage of any of the medications being reflected in neonatal outcome. So when it comes to program labor, it is something which is supposed to be used by all, at least to give a little bit of pain relief, having patients full cooperation at the same time, making it a little bit of pleasurable experience. Though we know and we know this fact that labor pain is the highest degree of pain with regards to any in comparison to any of the pains in the world. But again, that's a pain where a patient, if has a significant pain relief, will be able to cooperate and will actually remember those events well, as compared to having no pain relief and who keeps on cursing at the end of the delivery that I would not be able to have next pregnancy because of all the events or pain that she experienced in the process. So I think program labor is something which is a right of all the antenatal females and should be introduced. With regards to customization of the protocols, that is fitting to the obstetrician, at the same time presence of anesthetist and neonatologist would actually improve upon a little bit of outcome. Thank you so much.
So actually that was a very fruitful and sir, very one of the best slides from you, sir. And program labor is one of the topic actually so much no one is doing, I think so nowadays. Normal vaginal deliveries and it is nowadays
basically program labor is a need of an hour nowadays, because we cannot work for whole day and whole night. So program labor involves all the antenatal full-term patient will be coming to your OPD in the morning. The patients with the good cervical score you are admitting, and as Munjal has rightly said, you are monitoring the labor, giving them the best option of analgesia, and properly monitoring will be done. So by end of your OPD, you will be free with all the delivery, and so monitoring will be much more comfortable. Those who require urgent care, like PPH and everything, will be managed in a daytime hours. So program labor is now hour of need for all of us if we want to enjoy our life and to live a longer life.
Yes. Thank you so much.
That's it talk, Dr. Munjal. Really a pleasure to hear your talk. And we have also been following, your highly musical talent. You're a very artistic personality. All your music which you upload on Facebook. So wonderful. Congrats on that also.
Thank you, ma'am. Thank you so much, ma'am.
Absolutely multifaceted and very, very, very nice presentation. A lot of messages. And I think this is the way to go.
Yes, thank you, ma'am.
Labor. Yes, very nice.
Thank you, sir. Now I would request Dr. Charu Bapai ma'am and Dr. Amol Lunkar sir to present a vote of thanks for today's webinar.
Yeah, I
Would you like to add something on program labor?
we'll ask Lilo ma'am whether she wants to speak on program labor a bit.
Something you want to add on program labor? Yeah. Lilo, you want to add something on program labor? Last lecture?
I think we've seen that as well as in ART regulations, as well as in safe and healthy motherhood, there are many, many things we've got to observe. And if everybody takes that in consideration, life for our offspring is going to be better. The early one is embryos, the later one is children. So I think everything that you commented was super. And I hope it's going to be cast on and carried on in the future for our daily work.
Thank you so much. Thank you. Yes, yes, we can go ahead, Kanchan. Yes.
Yeah. So thank you, Lilo madam, for your closing remarks. And with that, we come to the end of our cutting edge webinar hosted by POGS along with the Ahmedabad OBGYN Society. And we are indeed very fortunate to have had some great discussion here regarding the ART bill as well as programmed labor. So to begin with, I would like to thank Lilo Mettler ma'am for having spared her valuable time and given her fantastic inputs on this program. I'm sure she leads an extremely hectic life and, you know, she defies age and aging. So ma'am, we indeed look up to you and we hope to continue to work just like you do. Thank you for being here. We also thank our esteemed guests of honor, Dr. Parul Kuddawala and Dr. Mahesh Gupta for being here and blessing the webinar. Along with that, we thank the Ahmedabad OBGYN Society, especially Dr. Munjal for his contribution towards the academic session, Dr. Parth, Dr. Ashish for being here, and of course, Dr. Meenu for having given the fantastic talk. Our very own Dr. Ashish Kale, thank you for sparing your valuable time to be an esteemed chairperson here. POGS is always a great support. It's like family. So Dr. Aarti and Dr. and Dr. Meenakshi, thank you for being here. Thank you for, continuing the association of us with POGS and along with the cutting edge webinar. Amol, you would like to add a little more? Are you here?
Yes. So, Charu madam, on behalf of, again, Pune Obstetric and Gynec Society, I thank the Ahmedabad Society for making this webinar happen and for associating with us. So I thank all the esteemed faculties, delegates for this attending this webinar and making it a fruitful academic session for all of us. Thank you. Thank you.
And thank you, Amol, because, Indira IVF, Amol, they were a part of the ART bill team at the national level. So whenever I was having some confusion, I would pick up the phone and ask Amol, isko kaise kar? Isko kitne saal ke liye registration hai? Iska kya karna hai? So he is always helpful. Whenever anybody has a medical legal about the ART bill, he is the right person to go to and ask.
Yes, ma'am. Thank you. Thank you, madam.
I think our very own Dr. Kanchan Durkar did a great job by being the MOC, and we could never not have hosted this program without the active support of Mr. Prasad Kulkarni and team BSV. Thank you so much for your cooperation regarding the technical support. Always a pleasure to meet Dr. Vaishali on screen, off screen, in front of the screen, behind the screen. So once again, a very happy Gudi Padwa to everybody and kindly enjoy your evening. Thank you so much. We take your leave. Thank you.
Thank you so much. Thank you so much.
Secretary Ahmedabad Society and Dr. Sunil Shah, who's the president of Ahmedabad Society. At the moment, he's in the US, so he could not join. So a special thanks to both of you for
Thank you on behalf of him as well.
Thank you so much.
And best wishes, Meenu madam. And I am sure that we are going to follow your footsteps of success, madam. All the best, madam.
Thank you.